So good morning students. Today I will discuss about the topic aggressive periodontitis. So this aggressive periodontitis is commonly seen in the age group less than 30 years. It is characterized by rapid attachment loss and bone loss and without large amount of the plaque and calicles. And there will be family history will be there in case of this aggressive periodontitis. So what are the bacteria that are associated with this aggressive periodontitis is Actinobacillus actinomycetum comitans. So this aggressive periodontitis is associated with host response abnormalities such as phagocytosis, chemotaxis. So hyperactive macrophages you see in this aggressive periodontitis. So there will be excess production of the prostaglandin like interleukin, prostaglandins and interleukin 1. So this disease might be self-arresting. So what are the different clinical features of this aggressive periodontitis? Previously, this is called juvenile periodontitis. Usually around puberty and around 20 years, you see this localized juvenile periodontitis. The amount of the bone loss is 3 to 4 times faster when compared to the chronic periodontitis. And this attachment loss usually affects the first molar and the incisors. So usually the inflammation is not clinically seen. There will be minimum amount of the plaque that rarely mineralizes, and there will be increased level of the Actinobacillus actinomycetum comitans and Porphyromonas gingivalis. So what are the different features of the localized aggressive periodontitis? So this maxillary incisors, they migrate in the distolabial direction, and you see the midline diastema. And there will be increased mobility of the teeth. You might see periodontal abscess, and the root surfaces are usually sensitive. So this, you can see the elevated level of Actinobacillus actinomycetum comitans, the active site of this localized aggressive periodontitis. So the incidence of these bacteria is greater in the younger person when compared to the older people. So in these younger people, they experience more amount of the destruction within short period of time. So this is important for diagnosis in early conditions. So usually this area is lesion to, this lesion is localized to the incisor and the first molar. So why it is localized to these incisors and molars? This first permanent teeth to erupt in the oral cavity is a molar, first molar and the permanent incisor. So this bacteria will evade the host defense mechanism, and following the initial attack, the host will produce the antibodies which improve the phagocytosis of the bacteria so that it will prevent the colonization of these bacteria to the other sites. And this bacteria will lose the ability to produce the leukotoxins so that the lesion is arrested in the incisor and the molar region, or it is progression of the disease is slowed down. So and other bacteria which are antagonistic to this AAC bacteria will colonize the localization of this bacteria to the other sites in the mouth. So this will localize the lesion, the only incisors and molars, and it will localize the further tissue destruction. So other reasons, so because denuded root surfaces where there is absence of cementum, these areas will be attacked by this bacteria, and it will allow the bacteria to penetrate into the root and colonize the site. So what radiographical changes you see in this localized aggressive periodontitis? Usually the lesion is bilateral, will affect the first permanent molar and the incisors. Usually the type of the bone loss is arch-shaped. The type of the bone loss is arch-shaped, extending from the distal surface of second premolar till the mesial surface of the first molar. So what clinical features you see in the generalized aggressive periodontitis? So the lesion is limited, information is needed. So usually it will affect the condition in the patients 30 years or more. Even older patients are also affected. You see the bone loss and attachment loss affecting 3 or more teeth other than the first molars and the incisors. The nature of the disease is episodic, So there will be certain periods of the inactivity which last for weeks, months, or years. So what bacteria you see in generalized aggressive periodontitis? You see Actinobacillus, Actinomycetum comitans, Porphyromonas gingivalis, Fusobacterium nucleatum, Campylobacter rectus, and spirochetes. So this episodic nature of the disease will produce two different types of the tissue response. In destructive phase, there will be the tissue will appear severely inflamed, ulcerated, and fiery red. So there will be bleeding with or without stimulation. Suppuration will be there, active attachment loss and bone loss will be there. In non-destructive phase, the tissues will appear pink with some stippling. There will be lack of inflammation. The probing will reveal deep pockets. Bone and attachment loss levels will be appearing stable in non-destructive phase. So non-destructive phase, the tissue will appear almost normal. Next, associated with certain systemic complications. In case of generalized aggressive periodontitis, there will be weight loss, mental depression, general malaise. Systemic conditions which predispose a patient to this generalized aggressive periodontitis, or it can be chronic neutrophil defects or any leukocyte adhesion deficiency. Any functional deficiency in the polymorphonuclear leukocytes or impaired chemotaxis and phagocytosis, all this you can see in this predisposing this condition to the generalized aggressive periodontitis. So in this figure, you can see the radiological changes. See, there will be severe amount of bone loss affecting minimum number of teeth. Majority of the teeth are affected by advanced bone loss. What is the prevalence of this disease? So usually it is seen less than 1% in US and other countries. So the prevalence is higher in the African-American citizens. So gender difference is unclear. So distribution of the disease by gender among the groups. So prevalence is higher in the African-American citizens in males when compared to the females. And the reverse is true for the white people. So what makes the patient at risk for this generalized aggressive or localized aggressive periodontitis? So AAC bacteria is found in larger number in the localized aggressive periodontitis. So this AAC bacteria will produce strong leukotoxin which kill the neutrophils. So different strains of the AAC will produce different levels of the leukotoxin. Highly toxic strain produce greater amount of leukotoxin. So the people with the disease are more likely to have highly toxic strains. African-American in particular, they are more likely to develop toxic strains of the AAC bacteria. So what are the other risks? So defective neutrophil function is one another finding. So you can see the depressed neutrophil chemotaxis and phagocytosis is common for both forms of the aggressive periodontitis. So this neutrophil dysfunction may have a genetic basis. Not all the people with this function will having this aggressive periodontitis. So what is the treatment of the aggressive periodontitis? Now we'll know. So it depends on the type and the degree of the destruction. So aggressive forms usually will have poor prognosis. First, extraction of the teeth having severe amount of the bone loss and periodontal therapy, where we have to give oral hygiene instruction. We have to control the plaque. Then you have to do debridement with or without flap surgery, do irrigation with chlorhexidine, and home rinsing with chlorhexidine. You have to advise the patient. And for flap surgery, if needed, you have to place the bone grafts in the areas where they are having bony defects. And when root resection is needed, we'll perform root resection or hemisection, depending on the condition, followed by frequent maintenance visits after 1 month or 3 months or every 6 months. So what is the treatment for the localized aggressive periodontitis? First, antibiotic therapy to eliminate the AAC bacteria from the tissues. So you have to give tetracycline or metronidazole combination with amoxicillin or doxycycline can also be given. In case of tetracycline, you give 250 mg 4 times a day for a period of 2 weeks. Careful monitoring of the younger patients with generalized aggressive periodontitis. Because the rate of the disease progression is very faster in this generalized aggressive patients. The maintenance for every 3 weeks or less is needed. The disease is an active state. Periodontal therapy, which includes debridement in combination with antibiotics, very strict block control you have to advise, or rinsing with chlorhexidine, and periodontal surgery, the cases where there is deeper bone loss or deeper pockets. So combination of antibiotics which you give in this aggressive patients, you can give combination of amoxicillin along with metronidazole or amoxicillin or doxycycline or clindamycin also can give. The local therapy in the form of gels, chips or fibers also in given. So in this class we have discussed about the aggressive periodontitis. What are the clinical signs? What are the different clinical signs? What radiographical features you see? What are the different risk factors for this aggressive periodontitis? And what is the treatment of the periodontitis? Okay, students. So with this, we'll conclude the class. Thank you.